Cancer Unit. She chairs the Hereditary Breast Cancer Thematic Group within the European Reference Network of Genetic Tumor Risk since 2017, and she is an active member of the International Research Consortium, SIMBA, working in hereditary breast cancer. She's interested in unraveling the challenges of implementing the advances in diagnosis of hereditary cancer susceptibility to clinical practice. Her translational research in breast cancer is focused on identification of biomarkers and mechanisms of resistance to targeted therapies for BRCA-associated tumors in collaboration with the Experimental Therapeutics Lab at BIO. So thank you, Judith, whenever you want.
Thank you, Christina. Thank you, Robert. It's a pleasure to be here for the first time. I don't know how, can you hear me well? There's a lot of echo? Okay, it's fine, or echo? Okay, so I'll put like this. Okay. So I'm delighted to give this talk intended to kind of give an overview of how germline alterations have reached the oncology field and how these are being used for precision medicine. In this regard, I first would like to start with some historical perspective. Probably many of you remember this first picture of the family G, what was drawn by Dr. Warthins and published in 1913 about a family in which uterine and colon cancer were transmitting in different generations. It took more than 50 years for Dr. Lynch then being able to collect this family back, and then in the mid-90s identified that this family was related with a mismatch repair gene mutation, if I remember well, in MSH2. So this has been a long way. More recently, we have finally landed in the era of precision cancer medicine, mainly aimed to identify targeted therapies and targets in the tumor or in the blood that can be used for precision medicine so that each individual can benefit the most from each of the drugs and with the less side effects. So in this regard, I will give you initially an overview of how this, in terms of germline alterations, can be used for this precision cancer therapy, and what are the main issues that we kind of like think about when we are ordering this germline or when we are using these germline alterations. First, I think we all need to identify which are the germline alterations that are targetable and which actually have a drug that can target that alteration and be really effective. When this lands in the era of cancer therapeutics, it is very likely that there will be an increase in demands. There will be speed. Oncologists will request a turnaround time much faster, so we will have to be prepared to be able to give those results in a much faster way. And finally, what's actually beyond the therapeutic implication? What is indeed within the germline alteration that also matters and has a lot of medical, familial, social, and ethical and psychological implications. So we will start with a simple table of some of the main therapeutic targets for patients with germline alterations. And at the end of the talk, I would like you to count how many of these drugs or alterations have actually ended up with a benefit in overall survival. So in breast cancer, for instance, germline mutations in BRCA1 and PALB2 are targetable for PARP inhibitors and platinums. TP53 germline alterations are also targetable in terms of early breast cancer if this is being identified in order to avoid radiotherapy or consider prophylactic mastectomy. I think this is also a way to target this. And then for individuals with the P10 mutations, PI3K inhibitors might also work very well. For ovarian cancer, there is a lot of data that both germline and somatic BRCA1 and 2 mutations, as well as a genomic signature called homologous recombination deficiency, identify tumors that are very sensitive to PARP inhibitors. In prostate cancer, PARP inhibitors have specifically been developed for patients with tumor alterations in any of the homologous recombination repair genes, but we will go more in detail later on about this. In pancreatic cancer, also patients with the germline BRCA1 or 2 mutations can be targetable with a PARP inhibitor after a platinum-based chemotherapy. And then we have both colorectal cancer as well as all cancer types, so it's an agnostic marker for MSI or mismatch repair deficiency according to immunohistochemistry to treat these patients with advanced cancer with anti-PD-1, so with immunotherapy, either nivolumab or pembrolizumab. And then there are also other less common tumor types, such as renal cancer with germline von Hippel-Lindau gene alterations that can benefit from an HIF-2 alpha inhibitor, belzutifan, NF1 with a MEK inhibitor, and finally medullary thyroid cancer with RET mutations that can also benefit from RET kinase inhibitors. In this talk, I would like to focus a little bit on colorectal cancer and all other cancer types associated with defective mismatch repair, prostate cancer also as an example, and finally breast cancer, which is my area of expertise. So yesterday, there was a very nice talk by Dr. Nicolene Huger-Bruggers talking about how this field has evolved, even in the field of prevention, and this was mainly based on microsatellite instability. As you probably know, these microsatellites are repeats of 1 to 10 nucleotides that are along the genome, either in coding regions or non-coding regions. And since they are very repetitive, at the time of the replication, the DNA polymerase may easily slip and cause replication errors. MLH1, MSH2, MSH6, and PMS2 are the mismatch repair proteins that are in charge of repairing these replication errors. If they don't work properly, they cause a number of increasing mutations, usually frame shift mutations, that are finally mutagenic. So the accumulation of these mutations per tumor in mismatch repair deficient tumors, so those with Lynch syndrome, for instance, creates a lot of tumor-specific neoantigens. And these tumor-specific neoantigens, what they do is that they attract the immune system. And that's the reason why we see those localized colorectal cancers with a high level of tumor-infiltrating lymphocytes and these lymphocytic reactions, which gives them some kind of good prognosis at the early stages. Nevertheless, tumors are quite smart, and they evolve in order to protect from this immune attack. So there is a way to escape from them, which is that if PD-1, this receptor in the T cell, recognizes PD-L1 being secreted by the tumor cell, then this tumor cell is not being identified as a foreigner, but as someone who's a friend, and therefore the tumor cell does not activate any immune attack. So this led to a Nobel Prize by James Allison and Tasuku Honjo in 2018, because preclinically they identified that by blocking PD-1 or PD-L1, the tumor cell could evade the immune attack. And this was the basis of the immunotherapy in tumors with mismatch repair deficiency, including Lynch syndrome. And here we have the first proof of concept back in 2015. Only 48 patients were enough to show that immunotherapy was very effective in tumors with very advanced stage and MSI. Here you can see only 13 patients with mismatch repair deficiency colorectal cancer, 10 that had non-colorectal cancer but were also mismatch repair deficient, and 25 that were mismatch repair proficient. And many of them, among the mismatch repair deficiency, had Lynch syndrome. And here, welcome to the field of oncology, waterfalls, and Kaplan-Meiers. I hope you don't get bored of them. But here I can show you the increased responses and the decreased in mortality in patients with MSI-high tumors treated with pembrolizumab. You can see here in the left an overall response rate of 62% among colorectal cancer patients and 60% also among non-colorectal cancer patients and MSI. This translated into a decrease of the tumor size, and finally, this also translated into a benefit in overall survival in patients with advanced colorectal cancer and mismatch repair deficiency treated with pembrolizumab. So this moved forward, and these kind of drugs were put in earlier stages of the disease. In this case, these are the results that were presented more or less a year ago at ESMO 2023, 5 years after with 5 years of follow-up of the first line in metastatic setting of pembrolizumab compared to chemotherapy for colorectal cancer tumors with MSI. And here you can see again a great benefit at 5 years in overall survival among these patients, and a hazard ratio of 0.73. So there is more than 10% decreased in mortality at 5 years among those who have MSI tumors and are treated with pembrolizumab compared to chemotherapy. So I think no one get enough with this, and the idea was to move this into earlier stages of the disease. So it's not only tumor cells that can express PD-L1, but also dendritic cells that also have some kind of immune evasion of being attacked by T cells through very similar mechanisms to PD-1 and PD-L1, which is through the receptor CTLA-4. And there is also an inhibitor of CTLA-4, ipilimumab. So Miriam Chalabi from the Netherlands, a couple of years ago, they started a clinical trial in patients with colorectal cancer and MSI-high before they underwent surgery by giving them 2 cycles of nivolumab, an anti-PD-1, and ipilimumab, an anti-CTLA-4. And they look at the number of responses at the time of surgery. And here you have, among all these individuals who had this immunotherapy before surgery, 95% of these patients had only 10% of residual tumor at the surgery, and 67% did not have any tumor whatsoever at the time of the surgery. So these were really very, very good. And as Dr. Venuk wrote in his editorial in the Precision Oncology paper, they were like too good to be true, but they also meet that statement that they are too good to ignore this threshold. And I think we have to keep in mind that at least among all those patients with colorectal cancer, those 10–15% that might be associated with MSI-high or defective mismatch repair can benefit from checkpoint inhibitor therapy to treat their tumors. And I think this is really a big advance in the terms of precision cancer medicine. What else can we learn from here? That this might be a new point of entry of identifying patients with Lynch syndrome. As Dr. Stadler also reported in her talk 3 or 4 days ago, I think it was the first day, the experience accumulated in Memorial Sloan Kettering Cancer through the IMPACT study has proven a lot of evidence that among all cancer types, 2% of them might have MSI-high. Among those that have MSI-high, 15% are associated with a germline mutation, and that clinical criteria are not sensitive enough to identify those tumors that have microsatellite instability. My bottom message here is that if we are undergoing and if we are requesting microsatellite instability or immunohistochemistry of the mismatch repair proteins, please refer those patients for germline genetic testing. They might have a Lynch syndrome, and there could be potential implications for their risk of other cancer as well as for their family members. So we can provide a very comprehensive assessment and care of our patients and their families. And this has translated, of course, into clinical guidelines in all different fields, not only pathologists but also, or geneticists, but also among the oncologists, that deficient mismatch repair status or microsatellite instability in colorectal cancer can assist clinicians with genetic counseling, can help to identify patients with Lynch syndrome, and should be done to select patients for immune checkpoint inhibition as part of the initial molecular workup. I think this is a big step forward from what Dr. Warthin identified at the beginning, a century ago, of those families, of those members of that family that were deceasing due to uterine and colorectal cancer. And I think we have to congratulate everybody to have reached this point. Now, I will change gears a little bit and go to the field of homologous recombination repair, where BRCA1 and BRCA2 are two essential proteins for genomic stability. They have a very important role at the time of replication of the cell, because if there is any double-strand break at that point, they are the ones that can stop the cell cycle and promote the repair of that double-strand break in an error-free way. Otherwise, if they are lacking, if they are mutated, there is homologous recombination deficiency, there is genomic instability, and this causes tumorigenesis and it appears, and cancer. So how this double-strand DNA repair works by homologous recombination, it's quite a very complex pathway that I'm just trying to summarize here in order to provide you some introduction for how PARP inhibitors are working in this field. So it includes a machinery of censoring the double-strand break, mediating and stopping the cell cycling, and finally recruiting RAD51, which is this recombinase that at the time of the replication fork is able to invade and look for the homology search and the strand exchange in order to copy that double-strand break that is broken and copy exactly from the template and then provide a repair that is error-free. So this is actually, this homologous recombination repair is the target of PARP inhibitors. And PARP inhibitors have two mechanisms of action. One is inhibiting the base excision repair and therefore leaving single-strand breaks unrepaired by the base excision repair. And the second one is by trapping this PARP enzyme into the DNA strand. Therefore, in any of these cases, when the cell starts replication, this translates into a double-strand break. If the cell is homologous recombination proficient, there will be a DNA repair, as I showed you before, and the cell will survive. But if there is a homologous recombination deficiency, maybe due to a BRCA1 or 2 mutation or PALB2, or so on and so forth, there will be no DNA repair, genomic instability, and finally cell death. So this is the mechanism of action of PARP inhibitors, and it's very similar to the mechanisms of platinums. How many PARP inhibitors do we have in clinics right now? So we have at least 4 of them. And they have already been approved in different tumor types: ovarian, breast, pancreatic, and prostate cancer. And there are different biomarkers for PARP inhibitors. The approved one is germline or tumor BRCA1 or 2 mutations, platinum sensitivity, other homologous recombination repair gene mutations, and finally, genomic homologous recombination deficiency by genomic scars. And I will start with prostate cancer. So we did have first, in 2015 as well, the proof of concept clinical trial. So patients with very advanced prostate cancer who had received hormone therapy and chemotherapy, and they were treated with olaparib in 2 different groups. Some had tumor homologous recombination repair deficiency, a mutation, and the other ones did not have it. And the trial proved that among those that had the mutation, the median survival, from progression-free survival, was 7 months longer than among those that did not have a homologous recombination repair alteration. And this proof of concept then had to be validated prospectively in another clinical trial, TOPAR-B, and here we start seeing differences in response to olaparib according to the gene mutation, the underlying tumor gene mutation. In prostate cancer, development has been done based upon tumor testing. And we see that in BRCA1 and 2, the median progression-free survival, so from the time they analyze how the patient is at that moment until the disease progresses, is 8.3 months. For ATM, it's a little bit shorter, 5.8, and for the other tumors, tumor genetic alterations as well. And you can also see here in the waterfall how BRCA1 and 2 benefit much more than some ATM and CDK12, PALB2, or other tumor types. So not all gene mutations kind of respond as well to PARP inhibitors as BRCA1 and 2. And we will go into a little bit more of detail comparing BRCA1 versus BRCA2. As many of you already know, BRCA1 mutations are not as common in advanced prostate cancer patients as well as BRCA2, and they also do not respond as well to olaparib. You can see here again one of these typical oncology figures, the waterfall. Down means that they are responding very well, and most of the patients that are responding are BRCA2 carriers instead of BRCA1 mutation carriers. So why do you think this is happening? Aren't they very similar? They are not so similar. And one important thing, and that's where I argue in favor of working together molecular pathologists, clinical geneticists, lab geneticists, and medical oncologists, is that we need to understand the biology beyond each of these tumors. And what is important in these tumor suppressor genes is that there has to be a biallelic inactivation in order to cause homologous recombination deficiency. And not always that's what is happening. You can see here very well that in this series of Foundation Medicine, that only 40% of prostate cancer, advanced prostate cancer, with a BRCA1 mutation have a biallelic inactivation. 60% of them did not have a biallelic inactivation, so it is very likely that BRCA1 is still working there and it's able to repair the damage caused by the PARP inhibitors. On the other hand, in BRCA2, we see that this proportion is not the same. So there is much more biallelic inactivation in BRCA2. So it's important that we remember this if we really want to give targeted therapy to our patients. And finally, this is the pooled analysis very recently published from different clinical trials in which they finally break the response to PARP inhibitors according to the tumor mutation. It can either be somatic or germline. And I want to call your attention to the benefit observed in PALB2 mutation carriers in terms of overall survival, but not in ATM mutation carriers, not in CHEK2 mutation carriers, not in BRCA1 mutation carriers, and the main benefit is coming from BRCA2 mutations. So patients with BRCA2 mutations in their tumor in advanced prostate cancer do benefit of olaparib, and they get a benefit in overall survival. But this does not apply to all the tumor types, to all the gene types. And this has translated, of course, into guidelines that are recommending performing tumor genetic testing in patients with advanced prostate cancer, especially if they are hormone resistant. And finally, breast cancer. So the field in breast cancer has evolved also quite fast, but it has not been the first one. The first studies were published in 2009, 2013, and we got approval of olaparib and talazoparib for advanced breast cancer in 2018, and then in early breast cancer in 2022. And I will do some quick overview of this, coming from studying in patients with advanced breast cancer, those that had been previously treated with other chemotherapies, most of the times more than 3 chemotherapies, And here you can see that both olaparib and talazoparib provided a benefit in progression-free survival, which means that they have the disease, and which is metastatic, and it's the time until death or progression of the disease. So there was quite an interesting, very interesting benefit for those PARP inhibitors compared to chemotherapy. Nevertheless, this benefit in progression-free survival did not translate into a benefit in overall survival in the metastatic setting. As you can see here, this crosses the 1, which means that there is a 10 towards a benefit, but still patients who receive standard therapy may live as long as the other ones. And with olaparib, the results are actually very similar. Therefore, in some European countries, for instance, such as mine, olaparib and talazoparib have not been approved for treatment of metastatic breast cancer patients. But things are different in the early stage. So patients who have a localized breast cancer and are BRCA1, BRCA2, and have a high risk of recurrence, means that the likelihood that the tumor may recur and be metastatic are very high, based upon different clinical criteria. And they can either be triple-negative breast cancer, so they do not express none of the hormone receptor, nor HER2, or they are hormone receptor positive, but have residual disease or have more than lymph nodes. So these patients, after a standard treatment, were randomized for 1 year to receive olaparib or to receive a standard therapy, which in the case of triple-negative was nothing for 1 year. And the primary endpoint of the trial was to identify invasive disease-free survival, so a recurrence that was metastatic, but also distant disease-free survival and overall survival. So patients that can be cured with the treatment of olaparib or placebo. And this is the slide that if you have to remember one slide from this talk, I wish it were this one. That the addition of olaparib in patients with early stage breast cancer improve the recurrence, improve the risk of having recurrence by 7.4% at 4 years, and with a very important hazard ratio of 39% decreased likelihood of recurrence. And the second slide would be this one, that this translated into a benefit in overall survival. So these are patients with early breast cancer who undergo a standard therapy, who have a high risk of recurrence, and they still are cured with the addition of olaparib to their standard therapy. As you can see here, the number of deaths decreased from 109 to 75 deaths, and this is the 32% risk reduction. These are big steps in the field of oncology, and to give you an idea for those that might be maybe over 40, 45, it's the kind of magnitude of benefit that also had trastuzumab in the adjuvant setting in 2005, or the benefit of T-DM1 in HER2-positive breast cancer after residual disease after neoadjuvant therapy. So these are the kind of results that really impact in the life of these patients. And I think that's what really makes an argument to encourage undergoing germline genetic testing in as many patients with breast cancer, especially early breast cancer, if they have a high risk of recurrence. And the benefits of olaparib was substantial and statistically significant among all the different subgroups of patients. So regardless of being BRCA1 or BRCA2, regardless of being triple negative or hormone receptor positive, and regardless of having or not received adjuvant or neoadjuvant therapy. So this prompted to the approval of olaparib in early breast cancer by EMA, specifically in the context of high risk of recurrence, which will be actually what probably makes the difficulty of who should we test. In St. Gallen, there was a consensus, right? That's where most of physicians and experts working in breast cancer, early breast cancer, gathered together to decide about recommendations. And last year, it was endorsed by 93% that adjuvant olaparib was beneficial for these patients, and the panel unanimously recommended genetic testing for patients who are potential candidates for olaparib-based therapy. And how do we put this in context? What does this mean in the overall field of young breast cancer patients with a BRCA1 or 2 mutation? I would like to call your attention that the germline mutation in BRCA1 and 2 in patients with young onset breast cancer does not impact on their survival compared to BRCA1 or 2 negative patients. So in this prospective trial performed in the UK, there was a comparison of the survival between BRCA carriers and non-BRCA carriers, and I think it's important to see that there were no differences in deaths by breast cancer, but that 3% of the deaths that were happening in BRCA1 carriers were due to non-breast cancer malignancies. So ovarian cancer, fallopian tube, primary peritoneal tumors. So there is the chance that when we identify patients who are germline BRCA carriers, not only are being cured of their breast cancer, but that we also pay attention to their risk of secondary tumors, ovarian cancer mainly, and that we put our efforts to reduce that death from other tumors that are preventable nowadays. And finally, I want to present you some data that was recently presented at ASCO in Chicago 2 days ago, which is also some results about the impact of genetic testing in BRCA1 and 2 in young breast cancer patients according to the time of BRCA testing. Here you can see it's an international cohort of almost 2,000 patients with breast cancer and a BRCA1 or BRCA2 mutation. And among those who had undergone genetic testing before their diagnosis of breast cancer, we see that their proportion of small tumors is higher, 61% versus 32%, and that most of them are lymph node negative. So this argues in favor that knowing your germline status before a breast cancer diagnosis helps to improve early detection of that breast cancer. And what other consequences this has? One is that impacts in disease-free survival, so the time that this person is free of any disease or recurrence, and also there is a trend towards a benefit in overall survival. So I think that by helping each and every of these steps that we can do around a comprehensive assessment of BRCA1 and 2 carriers, that we can help improve their survival and decrease their mortality. By testing as soon as possible, by giving them the best targeted therapy that we can, and then to also prevent other cancer risks that can also, all of them, impact in their survival. So it's the sum of all of them that finally impact in this field. So I hope that germline BRCA1 and 2 status ends up being one of the predictors that are being used at the time of workup diagnostic of an early breast cancer, and it helps to decide systemic therapy in early breast cancer, as well as other predictors that we are currently using to decide what time of chemotherapy, hormone therapy, and so on and so forth these patients need when they are being diagnosed. And what do we have beyond BRCA1 and 2? So PALB2, as you might recall very well, it's also one of the genes that are closely working with BRCA1 and 2, and there is data that has also been updated yesterday at ASCO, in which this clinical trial in the metastatic setting, patients with a PALB2 who were treated with olaparib had an 82% overall response rate. So 82% of PALB2 mutation carriers responded to olaparib, and this was updated yesterday, and it was 75%. So it's still a very high overall response rate. So in my opinion, I hope that PALB2 mutation carriers are being included in clinical trials and treated the same way as a BRCA1 or BRCA2, because they respond very well to these targeted therapies. Nevertheless, patients with ATM and CHEK2 mutations do not respond as well to olaparib, probably because they do not have homologous recombination deficiency. Which brings me, again, to the importance of working together and knowing the biology of what's behind these germline mutations. What is targetable is homologous recombination deficiency. Germline or tumor mutations are the biomarker that helps us in the clinic, but the target is homologous recombination deficiency. And we need biallelic inactivation. So let's look and let's ask for this biallelic inactivation, or let's analyze the functionality of the tumor before we treat these patients with a PARP inhibitor. Just a final message that in RAD51-CND, we were able to collect across 22 centers in Spain a nice collection of primary breast and ovarian cancers with this germline mutation and analyze their homologous recombination deficiency. And as you can see here, the prevalence of homologous recombination deficiency was much lower in patients with a germline RAD51-CND mutation than in patients with a germline BRCA1 or PALB2 mutation. And if we break this according to the hormone receptor status, those that had breast cancer and a hormone receptor positive tumor and a germline RAD51-CND did not have biallelic inactivation, and they did not have homologous recombination deficiency compared to triple-negative breast cancer or ovarian cancer. So this may probably respond well why there are differences in responses to targeted therapies in these tumor types, despite the germline mutation is the same. So finally, for those that are looking for homologous recombination deficiency, my only point to make here is that this is a dynamic tumor status, and genomic scars are able to capture the damage that this genomic instability has caused in the tumor, but it will stand homologous recombination deficient for the rest of the evolution. And it's important that we test it just before we give a drug. I would like to finish with this example, but I will skip it and end up with my final disease, with my final slide, which is just to share my thought that I really think that germline alterations are not conventional biomarkers. There are a lot of consequences and implications derived from these germline alterations. This is something that an individual carries for the rest of the duration of their lifetime. It has risk for other tumor types. There is also a lot of implications for their family members. So I encourage everybody to work together in order that we each of us provide an insight and something that helps to cure these patients. With this, I would like to thank your attention and thanks all the team, both at the breast cancer unit as well as the hereditary cancer unit, both in the lab as well as in the clinics that are working together to make this happen. Thank you.
Okay, so please, you have 2 microphones in the room, so you can go there for questions. And also, people that are online, they can write it on the chat, so we will read the questions. So, yeah, please, the last micro.
Hi. Thank you for this great talk. Could you comment on substratification of the BRCA BRCA carrier breast cancer patients with regard to tumor status?
Regard to?
Tumor status, LOH, BRCA-ness in the tumor.
LOH, BRCA?
BRCA-ness in the tumor.
Right. So most of the breast cancer tumors that appear in BRCA1 and BRCA2 do have biallelic inactivation. Not all of them, but the majority.
But was it tested in the Olympia or?
There is a lot of translational work going on right now, and I think we will have a lot of data coming in the next years. Yeah, and by subgroups. So we will get all that information, especially because some of these patients were treated with olaparib after having received platinum-based chemotherapy and other chemotherapies. So there could be some mechanisms of resistance. So I think we will get a lot of information from the translational research being done there.
Okay. another
Hi,
question there?
I'm Wouter Bossuit from the Genomic Score in Leuven. So thank you for the nice overview. I was wondering, when I looked at the data for the people which had their BRCA status known, they seem to have earlier detection of the tumor and also a longer survival after diagnosis. But is that, does that not just mean that they live for longer knowing that they had a cancer diagnosis, but is there also an effect on their total lifespan?
So you're talking about the Porsche study?
Yes, the one from Chicago.
Right, they didn't know they had a germline mutation. In that tumor, germline testing was performed on a research basis. Mm-hmm. Those patients didn't know they were treated equally. And that allowed to show that BRCA status was not a prognostic factor under the standard therapies.
Okay, thanks for the clarification.
So we have two questions in the chat. I will start with the one from Lisa Bradley. She writes, "Thank you, lovely presentation. You stated that knowing BRCA carrier status prior to diagnosis of breast cancer increased disease-free survival and overall survival. But by what percentage?"
In Olympia?
I guess.
I guess, right? Yeah. So the benefit, the absolute benefit was 3%. So it raises from those who did not receive olaparib in the overall population. Then there will be some subgroups, and there are some that benefit a little bit more than others. Thank you for the light. But in the overall population, the absolute benefit was 3%. I do understand that this 3% sometimes seems like quite low. But I think the point here to make is that we got to personalize. That means that each of these women who have finally developed breast cancer, who had a very high risk of recur, and if they recur, they have a high risk of death, or like having a very chronic disease. They are being cured by this, and the side effects are minimum. My clinical case was about this in 2 family members from the same family. So it's not the number itself, it's the impact and the final effect that this has in these women.
Thank you. Yeah, I'll do another question from the chat and then maybe one last question in the back. So Katie Snape writes, "Amazing talk. Do you think we should offer population screening for BRCA1, 2 and PALB2? And if so, do we need to rethink whether we offer screening versus risk reduction surgery in the population setting where penetrance is likely to be lower?"
That's a very good question. I won't be able to answer that in 30 seconds. I mean, I think that what I think is that the most we can do, as long as we can provide genetic counseling and assessment, it's the best that will impact in survivals of everybody and also in quality of life. It's not the genetic test itself. It's the information that these women receive by having an assessment at this time with human beings, with professionals, with genetic counselors, with clinical geneticists, with medical oncologists, that they can manage into their risk perception and then help them adhere to screening detection, risk reduction options, or get to targeted therapies. So it's everything. It's not by just having this available to you, but available with information, with counseling, with assessment, with dialogue. I think that's the important. I think we shouldn't miss this. I mean, if we can scale up this genetic testing by keeping the quality, we will be doing good. But if we lose that quality, then genetic testing itself will not save lives. It's my opinion.
So one question at the back.
Yeah, so that was actually quite my question. But I think, so I'll give an opinion. Sheila from Switzerland. I think as geneticists, we could do real good by promoting the idea of population-level screening for BRCA1 and 2 and PALB2, and actually providing preventive medicine so they don't have to see the oncologist. But thank you very much for a lovely talk. I really enjoyed it.
Thank you.
So I have one question. So you showed an example for olaparib when you get benefit in overall survival when you have early stage What about, do you have other examples of for example, belzutifan? When you have von Hippel-Lindau, we know the response is very good when you have the germline mutation, and the data for sporadic clear cell renal cell carcinoma doesn't seem to be that good. So is this something we can expect? I mean,
the differences between germline and...
No, I mean, when you have germline versus a sporadic, for example, in von Hippel-Lindau.
In von Hippel-Lindau. I don't have that experience.
I think it's very early data, so we still don't.
Yeah.
So what do you think? We will see these, or in other types of tumors?
I'm sorry, but I don't have that experience, not the exact knowledge to kind of be able to predict whether the benefits will be the same or not.
Okay. I think there are no more questions, nothing in the chat, no? So I think we are just on time, so thank you so much for a fantastic talk.